Welcome, friends. I'm Jennifer Jones, Vice President of the American Association of Kidney Patients, coming to you from the great state of Virginia for this year's Are You OK virtual education event, recognizing today, May 1st, as National High Potassium Awareness Day. On behalf of the AAKP, it's my pleasure to kick us off. For those who may be unfamiliar with the organization, the AAKP is the oldest and largest and fully independent, patient-led kidney patient organization in the nation. Since 1969, AAKP has been driving policy discussions on kidney patient consumer care choice and treatment innovation. Our mission is to improve the lives and long-term outcomes of all kidney patients through education, advocacy, patient engagement, and the fostering of patient communities. This Awareness Day was founded by the AAKP to bring the important topic of high potassium, also known as hyperkalemia, to the forefront of kidney patients' minds. Since 2020, AAKP has been educating millions of people about the risks of hyperkalemia and the availability of innovative treatments to prevent the most devastating impact of this condition. For this year's awareness campaign, AAKP continued to vigorously expand our reach and educational resources so kidney patients, their medical teams, and our allies across the kidney community can support this national grassroots movement to continue to mark May 1st, 5.1, as National High Potassium Awareness Day. As a kidney patient myself, I've learned the importance of knowing and understanding my lab values and following a kidney-friendly diet that's right for me. This Awareness Day is meant to help you gain more knowledge so that you can feel empowered to properly manage your potassium intake. Throughout this virtual event, you'll hear from Mr. Jerome Bailey, AAKP's Director of Patient Engagement and Advocacy, who will introduce and lead us through this year's virtual program. Dr. Anjay Rastogi, who will speak to us about the clinical aspects of hyperkalemia. Renal dietitian Sara Schaffer, an AAKP board member who will provide a glimpse into potassium management through nutrition. And AAKP's secretary and kidney transplant recipient Dale Rogers, who will share how hyperkalemia has impacted his life and how he manages his potassium intake, his personal potassium tips, and expertise with us. My friends, please sit back, relax, and enjoy the presentation. And of course, take some notes so you can put what you learned today into action tomorrow. Before we get started, here's a brief message from our National High Potassium Awareness Day, Are You OK campaign, and virtual event sponsor, AstraZeneca.
My name is Crystal King, and I am a CKD warrior. Kidney disease is an invisible illness. Love you guys. Initially, I was afraid of sharing my message. Getting the transplant does show him that his mom is strong, and I do all of this for him.
Thank you, Ms. Jones, for kicking us off. I'd like to echo her warm welcome. I'm so glad that you're joining us for this as we recognize National High Potassium Awareness Day. It is estimated that 3.7 million U.S. adults have experienced hyperkalemia, and among those, more than 48% had chronic kidney disease and or heart failure. This sobering number was a catalyst for AAKP to develop the Are You OK campaign and mark May 1st as National High Potassium Awareness Day. This campaign uses the scientific symbol of the potassium, the letter K with the positive sign, with the popular message, Are You OK, to encourage individuals with kidney disease to know their potassium level. The safe range for a blood potassium level is commonly considered under 5.1. Levels of 5.1 and higher may indicate hyperkalemia, making May 1st or 5.1 the key time for this annual Awareness Day. As you watch today's presentation, I hope that you will learn from the patient and the healthcare speakers and gather as many takeaways as possible regarding the importance of managing your potassium level. I encourage you to share what you learned today with your friends, community, and networks. Spreading your knowledge about high potassium can help save lives. Without further ado, I'd like to get us started by giving a warm welcome to our first speaker, Dr. Anjay Rastogi. Dr. Rastogi is a pharmacologist and a professor and clinical chief nephrology chief nephrology at the David Geffen School of Medicine at UCLA, with a strong dedication to providing the best comprehensive and integrated care to patients and their care partners. Dr. Rastogi, I'll turn it over to you.
Thank you. Thank you, Jerome, and welcome everybody to this, what I would say, a very important meeting and presentation. I'll be followed by an excellent dietitian, Sara, and then some patient feedback as well. So as Jerome mentioned, I'm a nephrologist. I'm also a pharmacologist, and today's presentation is going to be on hyperkalemia, and that's some of my titles. I do want to mention the Core Kidney Program at UCLA. This was started in 2016 with the intent of providing comprehensive integrated care. And the word integrated we use quite loosely, but it is very important. And when we say integrated care, it is all aspects of patient care. It's not just the medications we provide or the procedures, but it's diet, it's exercise, and mental health. And all those things are important when we are looking at the best outcomes for our patient. My email is at the bottom. So if there's any questions that we can't answer today, please do feel free to email us at corekidney@mednet.ucla.edu. So today's topic is potassium, and we'll be going over the periodic table. It's represented by K, and it's a very important mineral element, electrolyte in our body, serving multiple functions. And we'll do a deeper dive into what it does, number one. And number two is, when it's high or low, how does that impact our care? So what is potassium? So it's, as I mentioned, it's an essential mineral and electrolyte in our body that performs many vital functions. We'll be going over some of them. It's highly regulated, so that's very important. It's a certain blood level that is important, and kidneys play a very central role keeping these levels within limit. And this is not just for potassium, it's for any other mineral too, whether it be, or element, whether it be sodium, whether it be calcium, with phosphorus. Kidneys are very vital. And when kidneys don't work properly, they are disorders of these electrolytes and elements, and that leads to some problems that we'll be going over. Like I said, the focus today is on hyperkalemia, which is high potassium. But I also want to mention that low potassium levels can also be harmful and potentially fatal. So just please do keep in mind when we go over the lab values and how you check your potassium, make sure that it's not just the high ones that you're focusing on, but if they're low as well, then please talk to your healthcare provider and see what you can do to actually bring the potassium within normal range. And this is just going over the periodic table. As I mentioned, on the left-hand side, number 4 is potassium, K, with an atomic number of 19. So that's just showing that it's an important element with multiple functions in our body as well. So what are some of the functions of potassium in our body? So, and these are some of the bigger buckets that the potassium does. It's involved in nucleic acid, which is our DNA, RNA, and much more than that. And protein synthesis. It's also very important in regulation of cell volume, of pH, cell growth, and enzyme activation. One of the things that I want to mention over here is that there is something called extracellular fluid, and there's something called intracellular. That means within the cell. And potassium is one of the main positive ions within the cell, as opposed to outside, where sodium is actually the predominant positive ion. And the last point that I mentioned over here is actually quite critical. Potassium plays a central role in maintenance of what we call the resting membrane potential, RMP for short. And that is required for proper functioning of tissues like heart and muscles. And when there is a disorder of potassium, whether it be high or low, some of the main tissues that are organs that are affected are heart and muscles, and leading to manifestations that we'll be going over in a bit more detail. So the question comes up: what is your normal potassium levels? And I think that will be going on in a much more deeper dive, the range, and if you fall outside that range, both high and low. So this slide is a bit blurry. I apologize for that, but there are some couple of things that I do want to mention over here. So if you look at your left-hand column, it says tests, and right below that it says Comprehensive Metabolic Panel. That is, for short, it's called CMP. And these are all the electrolytes and everything that else that we order when we do some blood test. And here, as you can see, there are different things that we're looking at. The next column says result, which is the value. The flag, if it's high or low, is going to be flagged. The units that they're measured in, and then finally the reference interval. So the reason why I'm bringing this up is that as a patient, you should be more involved in looking at these labs. And if there is something abnormal, especially if it's flagged, then you should speak to your healthcare provider and find out why is it flagged and what is being done or can be done to address that flag. So let's go down that left-hand column. The first one is glucose. Then you have BUN, which stands for blood urea nitrogen. Then we have creatinine. And then we have EGFR, which is actually derived from the creatinine. Then we have the ratio BUN and creatinine. And then the electrolytes start. Sodium is the first one. And then, as you can see, potassium. And it's right 4.0. And the reference interval on the right-hand column is 3.5 to 5.2. Now, we mentioned 5.1 is the upper limit of normal, but that's not completely true, actually. It really depends upon your lab and what reference range and how they're calibrating their test. So what's important is, even though 5.1 will give you a rough idea that where your potassium is, but also look at your lab, that where you're getting your blood work done, and look at their reference range, because sometimes it might be as high as 5.3, the range. That's just the way their instruments are calibrated, or it might be 5.0. So do look at the reference range, and that's why I put this slide up here, that you should be looking at this and always take a copy. Now, a lot of these lab results are available on your apps, so you don't need a paper copy. But before, we had all these apps and electronic healthcare records, I would always give my patients a copy of their record so they can actually keep that. So once again, potassium, the range here is 3.5 to 5.2. Now, this is another way to look at it. We have the test results on the left-hand column. We have the reference range. Always look at that. And then, as you can see, there are three columns over here. There's February 6, 2014, November 8, 2013, and November 2nd, 22nd, 2012. Actually, if it's going from right to left, so 2012, 13, and 14. And why do I bring this up? Because the absolute values are important, but also the trend is important as well. So if you see and let's just take potassium for example. 3 years ago, your potassium, and here the range is 3.5 to 5.2. So your potassium is 4.0, then it's 4.4, then it's 4.8. So it's still within the normal range. But what you have to keep in mind is that it is getting progressively higher. So that should give an alert to you and to your healthcare provider that the next lab might be higher. So trends are very important. Absolute values obviously are important as well, especially if you have to take an action right away. But don't forget about the trends. And the trends you look at is when you look at like I showed over here, going back to 5, 6, 7, or 8 times your lab has been done. We'll go over why is high potassium bad. First of all, is it bad? And then second is, why is it bad? The question that I mentioned is, what if your potassium is low? The range is 3.5 to 5.2, but your potassium is 3.0. Is low potassium bad as well? And that's what we call hypokalemia. Now, I will leave it over here. Low potassium is not the topic for today, but please do keep in mind that if potassium is below your normal range, then it's a problem. And I don't know how many patients on peritoneal dialysis are attending the presentation today, But in peritoneal dialysis, the problem becomes the opposite. Instead of high potassium, it actually becomes low potassium, and sometimes we have to give potassium back to these patients. Now, this is an important slide, which actually I took it from the internet because it does really give you a good idea. So green in the center is normal potassium that we call normokalemia. And as you can see over here, the range, at least for this one, was listed as 3.5 to 5.0. Anything lower than that is called hypokalemia or low potassium. Once again, that's something definitely to keep in mind, but our focus is going to be on the right-hand side today, which is high potassium or hyperkalemia. And this is a predominant potassium abnormality that we see in patients with kidney disease, especially with advanced kidney disease. And here it's divided into three big categories: mild, 5 to 5.5, moderate, 5.5 to 6, and then severe, that is above 6. So those are the three big subdivisions within hyperkalemia. And as I mentioned, hyperkalemia means high potassium. And the focus today for the rest of the presentation is going to be on hyperkalemia and what can we do. And when I say we, it's the healthcare providers, patients, and their caregivers. What can be done to address this high potassium? So, who is at risk for high potassium? So, suppose you come with a potassium of 4.5 or 4.6, which is normal, but are you at risk for hyperkalemia now or down the line? So, these are some of the risk factors that we see that can worsen your potassium levels. Number one, by far the most important, is kidney disease, especially advanced kidney disease. Kidneys are the final organ that regulate the potassium in your body and maintain the potassium within a very tight or narrow range, 3.5 to 5.1, 5.2. Kidneys do have a lot of reserve, so hyperkalemia does not manifest itself till the very end. And by the end, meaning more advanced kidney disease like GFR below 30. Now, having said that, hyperkalemia can occur earlier too. It can occur as early as stages 2 and 3, or even before that, depending upon what the cause of hyperkalemia is. But normally, hyperkalemia manifests itself with more advanced kidney disease. Now, diabetes is the other main contributor for high potassium. And diabetes, by multiple ways, insulin deficiency, hyperosmolarity, what we call type 4 RTAs, medications that we use sometimes for the comorbid condition that we have diabetes, contribute to hyperkalemia. So the biggest offender when we look at kidney disease with hyperkalemia is diabetes. And also keep in mind the most common cause of patients ending up on with advanced kidney disease in the US is diabetes. So they go hand in hand. And if you have diabetes and kidney disease, as you can see, there's a much higher risk of becoming hyperkalemic. The third one that I mentioned over here is heart failure or just heart disease, and that also contributes towards hyperkalemia. Now, the number one cause of complication that we see in kidney patients is heart disease. So if you think about that, that is a perfect storm. You have kidney disease, you have heart disease, which we call the cardiorenal syndrome, and then you have diabetes as causing both. And the patient is at as a considerable risk of becoming hyperkalemic. Then what about medications? And we have a slide on this as well, but medications can contribute towards hyperkalemia. Some of them are life-saving, and I'll be going over that in a bit more detail. But some of the medications are over-the-counter, and you might not even think of them as causing hyperkalemia. And what are some of the common medications? It's a class of drug that we use quite often called non-steroidal anti-inflammatory drugs, NSAIDs. And what are some examples of NSAIDs? We have ibuprofen, we have Motrin, we have Aleve, and all these medications. So those can be causing hyperkalemia as well. Our wonderful dietitian, Sara, will be going in a lot more detail on diet. But there's a few things I want to mention about diet. There is a lot of debate where diet control can really help hyperkalemia. And the short answer, and there are different studies coming out that diet might not be as important. I would disagree with that. I would say diet does play a central role, but it's not especially with advanced kidney disease, not the only player. So Sara will go over that in a bit more detail, but diet does play a role. Now, what I do want to say about diet is that sticking with a diet is sometimes problematic, especially if you think about being diabetic, having kidney disease and heart disease. It really limits what you can eat. And a lot of the diet that's rich in potassium is also rich in other substances that are good for our healthy life. They're anti-inflammatory, they may high in fibers, antioxidants, so they're good for the heart. And I always say what's good for the heart is good for the kidneys at the end. So diet does play a role, and we'll be going over that in a bit more detail. And the last that I want to mention over here is who's that if you're constipated. If you have advanced kidney disease and or even on dialysis, then make sure that you're not constipated. Constipation versus hyperkalemia. And this is sometimes that we don't go over with our patients. And constipation is not just that you're having a bowel movement every day, but sometimes patients don't even know that they're constipated. It's always good to discuss your bowel movements with your healthcare provider. So this is once again something I pulled from the internet. Hyperkalemia is a medical term that describes a high potassium levels in your blood than normal, and these are some of the causes. We went over them. Diabetes is a very important player. Medications. We have congestive heart failure, impaired potassium excretion. You can see those two wonderful kidneys over there, and the kidneys are instrumental in regulating your blood potassium levels. And at the bottom right hand side, once again, you can see potassium with its atomic number of 19. How does hyperkalemia manifest itself? And what's quite interesting is that the symptoms are non-specific. The patients can present with what we call muscular weakness. They can present with heart rhythm issues, but this is something that they really don't present with most often. And this is where it becomes very, very tricky and critical. But what's most important is most of the cases of hyperkalemia are diagnosed when you go for your blood work, and they're mostly silent. And one thing that I want to throw out over here when I speak to our first year medical students and we go over hyperkalemia, if you look at the lethal cocktail that is used, the active ingredient of that lethal cocktail is potassium. And why is it potassium? Because it does not cause any pain or any other manifestations. So the important point that I want to mention from here is even though there could be some manifestation of hyperkalemia, most of the time they're non-specific and you will not even know that you have hyperkalemic. So you have to stay on top of your labs and follow with your healthcare provider. So hyperkalemia could be acute versus chronic. What is acute? Your potassium is 4.5 and then now is 6. So that is an acute rise. Or it could be trending up 4.5, 4.8, 5.1. Acute hyperkalemia is managed as an urgent or even emergent setting. And most of the times, if that is a case, your healthcare provider might send you to the ER. And there are different measures that they do. That are called the temporizing measures. They'll give calcium, they'll give insulin and glucose, they'll give some bicarbonate, and if nothing works, they will get you ready for dialysis. So that's the acute management of hyperkalemia. But what I want to talk more today is the chronic management. So where we can work as partners with our patients and their caregivers. So how do you manage high potassium? So first of all, manage the risk factors. We went over those risk factors already. Dietary management, Sara will be going over that in a lot more detail. Modify the medications, and I'll go over this. Now keep in mind you can modify them, but a lot of these medications are life-saving. And at least when we speak as nephrologists, we try to do our best to keep these patients on these medications. Potassium binders. Now, if you have done everything that you can, you have modified the risk factors, you have managed your diet, you have modified the medications, and if your potassium is still high, then get on potassium binders. We wrote a paper, and I can send you a copy of that, in 2015 when some of the new binders came out, that hyperkalemia from an acute condition became a chronic condition in which you can actually manage the potassium with binders. And then finally, you can adjust the diuretics. And if nothing works and you're still very hyperkalemic, life-threatening, then dialysis. So those are but I would say that this is the way we should approach or progress when the patient is hyperkalemic. Now, some other medications besides the non-steroidal, which I mentioned, ibuprofen, Motrin over the counter, but there are some other medications that actually can cause hyperkalemia. And these are the big groups: ACE inhibitors. You have probably heard these names: lisinopril and ramipril and all those prils. ARBs, the angiotensin receptor blockers, you've probably heard those valsartans and losartans and irbesartans and candesartans. Then mineralocorticoid receptor antagonists, MRAs, and those also spironolactone, finerenone, which is Kerendia that recently got approved, and some of the beta blockers, especially if they are non-specific beta blockers. Now, what's important to keep in mind is these are life-saving medications. It's easy to take these medications off, but if you take these medications off, you might not feel the symptoms, but in the long term, it can limit the advancement that we make in kidney disease and heart disease treatment, but also the lifespan. So it is very important that you work with your care team and say that I should be on these medications. And it's not that you need to be on these medications. You should be on the maximum tolerated dose of these medications. So if there's one thing you can take from today's presentation is go over your medication list and see if you're on these medications, especially the first three ones, which are more for kidney indications, the last one, and cardiovascular, which is heart. Beta blockers are more for cardiovascular disease. But make sure that you go over your medication list. So in summary, potassium is an important and vital electrolyte in our body. Both high and low potassium is bad for you. Hyperkalemia is often silent, so it doesn't cause so it's not like you're going to have a headache or chest pain when you're hyperkalemic. It's most often silent, and even when it presents, it's non-specific. So make sure that you follow your blood work. Understand your risk factors for hyperkalemia. Work with your care team to optimize your medications. Make sure you're on the life-saving medications as much as you can. Now, if you can't, at least we tried. And get involved in your care. Be an active participant and be your own best advocate. So with that, I want to thank AAKP for having me, and I will be around if there's any questions. I know we have some questions that have already come in. We'll answer those questions, and then I'll hand it over to Jerome.
Thank you, Dr. Rastogi, for that meaningful presentation for our AAKP members and viewers. And now I'd like to introduce our next speaker, Sara E. Schaffer. Ms. Schaffer has spent more than 15 years in kidney care, leading a variety of teams and projects. She most recently was the Vice President of Strategic Operations at Health Math Solutions, after several years as an Executive Director for the Center for Medicare and Medicaid Services kidney contract. Her focus remains on shaping the kidney care landscape to slow disease progression and better support kidney transplant and home dialysis treatment choices. Ms. Schaffer began her kidney career as a registered dietitian in acute and outpatient dialysis units and later managing outpatient dialysis facilities. We are honored to have Ms. Schaffer join us. Please take it away.
Thanks, Jerome. Thanks for having me, AAKP. My name, again, is Sara Eve. I am your friendly registered dietitian, kidney dietitian, and we will start the presentation. So, as the good doctor mentioned, right, the diet does play a role in your management of potassium, although it's so individualized based on your health history, your stage of kidney disease, and even your own medication profile. I'm going to kind of give you some of the signposts and guardrails as you go along your kidney care journey to look for with potassium and diet. So we're going to talk a little bit just about knowing your numbers. The doc mentioned a lot of those. We'll go over those just a little bit. And more importantly, really how to know yourself and to take that time and think about where you are in your health journey and how you could apply that to handling your nutrition and your diet. We'll talk about, different ways to manage your intake. We'll talk a little bit about the nutrition facts label, which is now more helpful for folks with CKD. And then just a few tips for meal planning and some substitutions and swaps. So most importantly, really know your numbers and know yourself. So take some time. And this echoes, I think, what we heard the doc just mentioned too. Know your blood work, your lab work, your blood work, whatever you call it. Also know your medications. As was mentioned before, trends are really important in your history. So as a dietitian, I would love when I would hear patients say like, I know I've been under 5.0, but it's also been creeping up, right? That's a sign that our intake has been changing perhaps. Sometimes folks also notice that perhaps in the summer, their potassium is high because they're eating so many new fresh fruits and vegetables. And then also really think about the holiday time. That might also be a time to tune into this. Sometimes we hear folks say that they were high over the holidays, right? Because it's a time they were eating special foods with special people and, making a departure from perhaps our typical intake. Also, take your doctor and dietitian recommendations. You know yourself the best. However, really put some stock into what they say and where things are going. Know what your go-to foods are and portion sizes. Again, really take some time and think about, most of us eat the same foods again and again. So really take time and be able to kind of recall some of the foods that you commonly eat and realistically what your portion sizes are. We'll talk a little bit more about portion sizes in a minute. And then I would also, in light of thinking about managing your potassium through your diet, I would think to yourself, how am I doing with my kidney diet in general? Where am I in my health journey? Is this a time when I'm doing better because I'm focused more intensely on it and maybe really want to track down, the milligrams? Or, is this a point in my health journey where I kind of just want to follow the rules and not put too much focus on it? So again, the tenet here for today is really take some time and think about where you are and just be realistic. So in those two different mindsets, if you are in a space where you really want to focus very closely on it, perhaps you've had hyperkalemia or high potassium, or you really want to track it, and that's very empowering to you. You can track your intake. Certainly there's apps now. You can use an old-fashioned pen and paper. Here's a plug for the AAKP nutrition counter, which is a little printable PDF, so you can look things up. Again, also a lot of the apps track potassium. Think about your portion sizes when you're focusing on a budget, right? So a low potassium food can be a high potassium food if we eat multiple servings of it. So again, the guidelines for potassium intake are, very individualized, but overall we can think of these kind of guardrails for what a food might be for high, medium, or low, or very low. You can see there high be more than 250, medium's kind of in between there, 150 to 250, low is less than 150. Again, it depends on portion size, but that's all per serving. And if you're in a space in your healthcare journey where you're like, I just want to follow the lists and kind of, as long as I know if I follow the list and I'm consistent, then, you might have a better chance of managing your potassium levels at the, within normal limits for you. So if you're in that space and you want to have a list, we really suggest to carry your list with you. You can copy and paste it on the notes section on your phone, or you could print out a little pocket guide. AAKP, again, has some great resources. Those are peppered throughout this deck. And so when you look back on it, you'll be able to look at those links. So if you want to follow the lists, you can see here, this is pulled right from AAKP. There's lots of lists that are super helpful of high and low, and you can just kind of follow the rules and stay within the guidelines if that's working for you now. And as I mentioned, nutrition facts are now more helpful. So in years past, they didn't have the potassium content, but as of a few years ago, that was added to the nutrition facts label. Again, just trying to make sure that we hit home the point that a low potassium choice is low per serving. So you have to do a little bit of math, but if it's 100 milligrams for one serving and you ate 4, right, that turns into 400 milligrams, which makes it, a bigger dent in your potassium budget. And then here, a reminder to check the mg, the milligrams, not the percent, right? So the average American typically eats a diet low in potassium, which doesn't confer all of the health benefits of some of the foods that are higher in potassium, right? So the average American, without kidney disorder, might shoot for 4,500 to 5,000 milligrams a day. It's certainly much lower for folks with CKD, more in the 25 to 3,500. Again, it depends on your CKD and your treatment. As the doc mentioned, folks who are on peritoneal dialysis often require additional potassium. But again, focus on the milligrams, not that percent, because the percent's going to be out of whack compared to the average American diet and not doesn't reflect really the CKD needs. And then also, I do want to call out that as they went through and made the nutrition facts label more helpful, they increased the serving size to be something that is more realistic. So I think in the past, we all kind of had that joke where it was like, oh, 2 cookies, that's not a serving size. I always eat 4. Well, the nutrition facts label kind of caught up with that, and they tracked a lot of, large segments of the population, and they increased it. So no longer just look at this, the serving size and be like, oh, I definitely eat 2 or 3 times that, because they have increased that. So in order to know what the milligrams of potassium that you ate were, you have to really count on that serving size. So measure to match is what we say with those serving sizes, and I'll go over those next. So again, portion sizes, really tracking anything really depends on knowing how much that was. And so over time, you'll get an eye for it. Just practice and learn at home. You'll be able to have an eyeball, measure it out the first few times, know what it looks like. If you're at home, use those same size bowls, plates, and utensils, right? So you have the kind of consistent comparison. Maybe use the middle size plate for fruits or vegetables. And then, once you measure it, you'll grow to have an idea of what it looks like on your plate. If you're out at a restaurant, ask questions. Really, servers are there. I think it's much more common for folks to be upfront about what they're eating or their health needs, if they're gluten-free or if they're CKD. And so please, feel comfortable just to ask. They should be able to give you a realistic answer, both on portion size and content. And then lastly, for portion sizes, consider how the food's prepared, right? So we've all done that thing where you've taken a handful of raw spinach and it was, a big handful, and then you cooked it down and it's this little tiny tablespoon, right? And so think about that raw spinach. You're going to get a lot more bang for your buck in some ways as far as how much you could eat as opposed to cooked spinach, right? Which is very concentrated, and therefore the potassium intake would be higher. Same with raw tomatoes versus tomato paste, right? Think about how many tomatoes are boiled down to make that very concentrated tomato paste. And the same with, fresh fruit versus fruit juices, how easy it is for us to drink several ounces of fruit juice, but how it's much more, time consuming, and you get more fiber if you eat the fresh fruit. So consider those options too as you think about portion sizes. Another plug there for the AAKP high potassium guide, that is printable in a pocket guide, a cute little PDF that you could easily, or you could save to your phone, or you could print and carry with you. And then just some tips for meal planning. Please don't feel like you're alone. Yes, the CKD diet, can feel restrictive, especially if we're eating to manage our CKD and our diabetes and our heart disease. But really, everybody needs a plan for meals. We all live busy lives. We spend a lot of time in front of the screen. Food is both very expensive and sometimes super cheap. So everyone could use a plan. Don't feel like it's just you that needs this. I really encourage folks to set it and forget it. Make some meals or snacks super routine and consistent. If you find that you skip breakfast and then that contributes to perhaps a poor choice at mid-morning, just eat the same thing for breakfast most days and just kind of take your brain out of it and just set it and forget it. Also, I try to recommend to folks to really be realistic about your schedule. If it's a dialysis day, for example, or you have a lot of appointments or family things going on, plan on an easy dinner. That might be a day that scrambled eggs and toast and berries and a cup of coffee, right? That's a fine dinner. No one's judging you on, the kind of dinners that we put on the table. And so just, make it realistic and make it easy on yourself where you can. Also involve others in planning. Again, I think there's a lot more conversations anymore about food and what makes us feel good and kind of, our individual, preferences when it comes to food. So, don't be shy. You can talk to your family or your friends, tell them if you need help, tell them if you're struggling to, follow the CKD diet. And then also, there's great online support groups. You can go to kidney recipes sites. AAKP Delicious has a channel on YouTube that is excellent. Just reach out and just don't be shy to share kind of, what you're going through and what you might need. And then, to go back to the first idea of this is, really getting to know yourself. So take some time and sit down and think, ask yourself why you eat, what you eat, when you eat. And that sounds kind of deep, but it doesn't have to be, right? So one example is that this is purely hypothetical, of course, but perhaps after a long day in the evening, 8 o'clock at night, you're standing in your kitchen, your day is done, and you're feeling a little bit, off or whatever. Maybe that's a time that you reach for a snack that might not be the best for your health, because in the moment it's just pleasurable, right? It just feels good. Think about perhaps some other things that might, kind of scratch that itch, if you will, taking a shower or a walk, texting with a friend, doing something, to manage your stress that doesn't rely on eating for pleasure. And then just a few substitutes and swaps. I'm the kind of person, I always like to try new things, but not everybody does. So if you aren't, be one of those people, pick a day of the week that you decide you're going to try something new and kind of stick to it. Do try Mrs. Dash. There's a lot of low sodium and kidney friendly, low potassium, seasonings out there. Do try new recipes. Again, plug in the AAKP friendly, kidney friendly recipes. There's so much out there anymore. Do swap out some of those higher and medium choices for lower choices. It does all contribute to our health overall. And do ask your dietitian for personalized recommendations. Dietitians love this stuff. We're usually super nerdy. We will Google it for you. We will do the milligram math for you. We will find those things. So please lean on your healthcare providers where you can. We are all here really to support you and lighten your load as you, walk on your journey. And then, as it often comes up, don't use a salt substitute. These rely on a potassium chloride instead of a sodium chloride. So while it might seem like it's something good for perhaps your hypertension or your fluid balance, really these high potassium salt substitutes are no good and enter in a lot of risk to the diet. So just best to stay away from those. And again, we have a lot on the AAKP site. There's the whole kidney-friendly recipes. There's a section on hyperkalemia. Remember, that's high potassium. I know it sounds like you ate too much kale, but hyperkalemia, it's almost like a little trick to think about it, right? Too many fruits and vegetables that are high. There's a whole site there you can go to in addition to all the other great resources that we're sharing today. And I'm sure Dale, as he talks about his journey, he'll share some of those too. And really just want to share, I know that everybody can go out and we can Google the potassium list and we can track these things. But I think sometimes when it comes to diet, what's really helpful is just having some kind of frank talk and having a little bit of, extra motivation and empowerment. So you got this, you can do it, lean on the resources around you, be realistic, and listen to your body, listen to yourself. And thank you so much for everyone's time today and allowing me to share my thoughts.
Awesome job, Sarah Eve. Thank you very much. Thank you for sharing your knowledge and tips with our AAKP members and viewers on National High Potassium Awareness Day. Next, I'd like to introduce Dale Rogers. Dale is Secretary of the AAKP National Board of Directors and an AAKP ambassador and a kidney transplant recipient. Dale has worked with his healthcare team to keep his potassium at a healthy level. He joins us today to share how hypokalemia has impacted his life and what he's done to manage his potassium intake. Take it away, Dale.
Hi, welcome to this year's Hyperkalemia High Potassium webinar brought to you by AAKP. My name is Dale Rogers, and I'm a kidney patient, and I've suffered from kidney disease since 1998 and went into total kidney failure shortly thereafter, ending up on dialysis. On dialysis, high potassium is very important because it can create problems in a person's life that can actually stop your heart, as you've already learned from our medical professionals today. Myself, high potassium was first brought on to me by diet, and I connected with my medical professionals that were able to help me find a diet that was better for my life, that took out some of the foods that I was eating and reduced the potassium in my life, and I was able to go on quite well. My next situation with high potassium that I learned about was potassium built up in my body and then in the cells, and then it dumped a load of high potassium, and then I had to connect with my medical professionals again that were able to quickly reduce that, and I didn't have that problem again. Later on, just 6 months ago, I had something new come up in my life that was dealing with medications that I was prescribed by my medical professionals that I had been taking for quite a long time, that later on um, came up and raised my potassium again. I ended up in ER with a low-grade fever, achy and tired, and fatigued, that they were able, through blood tests and what have you, they came up and found that the only thing that was wrong with me at that time at ER was that I had high potassium levels, and it was connected because of one of the medications that I had been prescribed to. The ER doctor quickly connected me with nephrology, and nephrology was able to lower my potassium, and I'm still on that same dose of medication, but it has not raised my potassium again. So we don't know why that medication level actually raised my medication level again, but being aware that medications can raise your potassium level is very important, and being connected to your medical professionals and having a connection with your medical professionals so that you can tell them what's going on in your life so that they can run the proper tests and procedures on you to help lower those things can be very important to you down the road. I've found as a patient myself that being connected to a patient-led organization like AAKP can be very detrimental to our lives, because AAKP spends a lot of time putting information together from our professionals and other patients to create educational materials that can help us learn prior to incidences like this, so that we can stop some of these things from happening that can make us sick in the future. I think it's very important as patients that we share our stories, share the information that we've gone through ourselves with other patients, so that they can connect with their medical professionals and keep some of these things from happening in their lives themselves. You can find at aakp.org that you can become a member for free as a patient, as a family member, and as friends, to connect yourselves with this information, these education and webinars that can greatly improve your lives. Also, as patients, we can share our stories through AAKP, and patients can become very familiar with these things and help other patients. And I believe the connecting with other patients can be a very strong tool in benefiting each other. And I'd just like to thank you for attending AAKP's webinar this year on hyperkalemia, high potassium, and have a great day.
Thank you, Dale. We appreciate you sharing how hyperkalemia has impacted your life. I want to say thanks to all three of our speakers, Dr. Anjay Rastogi, Ms. Sara E. Schaffer, and Dale Rogers. Before we close out our program today, we did get a few questions that came in from the webinar participants. I think this first question is for Dr. Rastogi. Are high potassium foods the only thing that can increase my blood pressure levels?
You mean potassium levels?
Blood potassium levels, sorry.
Yeah. So two things. Number one, I think Sara went over this. The high potassium foods are obviously something that you would want to avoid or restrict, but also eating a too much of low potassium foods, it's a quantity thing. So just saying that also. But yes, there are other things that can cause hyperkalemia or high potassium levels. We spoke about the comorbid conditions, whether it be kidney disease, diabetes, cardiovascular heart disease, and then most importantly, medications that can also. And those are things that you will need to speak to your healthcare provider to modulate that. And obviously, diet is very important as well. But medications are very, very significant. Sometimes simple medications that we think over the counter are safe are actually not safe. So please do. Looks like AAKP has a wonderful website. Go to that website or talk to a healthcare provider. What could be, but the risk factors that I discussed, managing them, and if they get worse, and sometimes they do, despite all the measures that you're taking, then that can lead to worsening of hyperkalemia.
We have another question for you, Dr. Rastogi, and it is, I understand that 5.1 may indicate the start of hyperkalemia, but my potassium level always seems to be slightly above that at 5.4. Is that okay if it's monitored pretty regularly by my doctor?
That's a great question. So a couple of things about that, and I did go over that the trends are very important as well. So looks like it is consistently 5.4, but it is high. That's not normal. But even if it was within the normal range, I think trending it out is important. Now, making assumption that 5.1 is the upper limit for this, and this person's potassium is running 5.4, what are the risks? And there are risks with that. If this was my patient, I would make sure that we bring down the potassium within the normal range as much as we can. Because what if there's an overriding insult? What they already have. What if, for whatever reason, they ate a high potassium diet? They was rich in tomatoes or all the other things that were discussed. That can put them at higher risk of getting what we call severe hyperkalemia. So we went for mild, moderate, and severe. So my approach to this is that I would try to normalize the potassium as much as I can. But monitoring that over time, if it's working so far, it's good. They can keep on monitoring it, but I would prefer to normalize the potassium so that we have more leeway.
Thank you for that response. We have a third question for you, and it is, I tend to have difficulties keeping my potassium level below 5.1. Can an acute hyperkalemic episode be more harmful or less harmful on my health and heart than maintaining a potassium level that is above normal?
That's another great question. So what the body sees, and we went over the membrane potential that potassium plays a very central role. It actually does see the swing. If there is an acute episode, a rapid rise, that is probably what that can set up a lot of these arrhythmias. So if the potassium is consistently above, was that the question? Sorry, Jerome. The potassium was above 5.1 for this individual?
It's she's having difficulties keeping her potassium level below 5.1.
Yeah. So, and I don't know what stage of kidney disease she is in. There's also stage 1 to 5 in dialysis, but I would try to keep it within range as much as possible. And if despite all the measures, including dietary modifications, then I would go with a potassium binder. There are binders that are available now that have data that show long-term safety and efficacy. Now, being a pharmacologist, I always say that drugs should not be a lifestyle substitute. But if you had done everything that you could, and despite that your potassium stays high, then I would prefer, I would put my patient on a low dose of potassium binder. The other thing that I want to say about diet, because we did discuss that at length, diet is great as long as you can stick with it. And sometimes, number one, they have a lot of other diseases, including diabetes and kidney disease and cardiovascular disease. that limit what they can take. And also, a lot of the diets that are high in potassium are also more heart and kidney friendly. So it's a real challenge, and that's why talking to a good kidney dietitian is very critical in getting your meal plan.
Thank you, sir. This next question is for Sarah Eve, and it is, I'm a dialysis patient. Does Medicare cover visits to see a renal dietitian?
Sure. So, again, to underscore the helpfulness of dietitians, yes, once someone is on dialysis, it's actually a requirement that a dietitian should be seeing you monthly. So, that's not something you should have to seek out. He or she should be following up with you. If that's not happening, you should definitely be talking to your facility manager, whoever runs a dialysis clinic, whether that's in-center, peritoneal, or home hemo. Definitely talk to them, because you should be having a dietitian talk to you every month, going over your lab work, your food choices, your overall body weight, and check in on all those things. And for folks who, I just want to make another plug there, for folks who are in earlier stages of CKD, if you are on Medicare, there is a benefit to see a registered dietitian for medical nutrition therapy. That's what we call, that kind of disease-specific nutrition counseling. And that, you do check with your plan to make sure, of specifics, but typically it covers folks 36 months post kidney transplant. And then also for folks with CKD, a certain number of hours and visits in the first year and second year, up to 5 visits or 3 visits. So please, if you do have CKD, there is a benefit there. Registered dietitians, again, we love this stuff. We will eat this up, no pun intended. And on the AAKP website, there actually is a link to be able to search for a renal dietitian that would accept your benefits. So please do that.
Thank you, Sarah Eve. And our last question goes to Dr. Rastogi, and it is, am I able to monitor my potassium level at home?
The short answer of that is not yet. So it's what we call point of care testing that is being actively looked at, but it is not available at this point that you can check. And there are a lot of reasons for that. The monitoring of the instrument, wide application, and so on and so forth. So at this point, it is not available, and hopefully it would be. There are a lot of research being done on that you can, just like even glucose, active monitoring of potassium in your blood, like with the continuous glucose monitors. So those are things that hopefully in the next 3 to 5 years will make more advances. But at this point, the short answer is no. But what I do tell my patients is to have a standing order of labs, that you don't have to call your provider, and you can go and get your potassium checked. Now, what I do advise my patients is that, number one, if you do get your potassium checked, if there's a standing order, then you notify us right away, because what if the lab comes in and nobody follows up on that? And the other thing that I prefer is that potassium be checked, the earlier during the day and earlier during the week. So if there is a problem, we can address that. After hours are always tough, and a lot of times you have no option but just to go to the ER. And the same thing applies for weekends. But you should talk to your physician and see if you are having recurrent hyperkalemia, labs are coming back higher on an ongoing basis, than having a standing order. Also, if you think you have a high potassium because of what you ate, it's good to have that. And also for these same kind of situations, it's good to have these potassium binders at home. If my patient has a risk for getting hyperkalemic, I give them a prescription for binders, and they can keep it at home and take it. And the patients would know, as long as they know which ones are high potassium foods, they should take that. I just wanted to reinforce what Sara said. Every patient who's on dialysis has designated dietitians who should be seeing them at least once a month. They are part of what we call the interdisciplinary team, the IDT, and that includes, besides the nephrologist, it includes the dietitian and the social worker, the nurses, and a whole group. So if you haven't seen your dietitian, or you think you haven't seen your dietitian, you would want to talk to your, as I said, facility manager and for the dialysis unit, and find out, or talk to your nephrologist, because most likely the dietitians have seen you, You just probably might not have been aware of that.
Thank you. Thank you so much. And that brings us to the end of today's program. Thank you again for joining us for this year's National High Potassium Awareness Day, Are You OK virtual event. And special thank you again to today's guest speakers, Dr. Anjay Rastogi, Ms. Sara E. Schaffer, and Dale Rogers, and our 2023 campaign sponsors, AstraZeneca and CSL Vifor. I hope you were able to gain some insight on why high potassium is an important topic for kidney patients and how to effectively manage your potassium level. Although National High Potassium Day is recognized every May 1st, it's an important issue year-round. So please continue to visit www.ruok.org anytime to access educational resources and on-demand content about potassium management and kidney disease. You can also follow us at RUOK 5.1 on Facebook, Twitter, and Instagram. We are excited to announce the dates of our 2023 events, the 5th Annual Global Summit on Kidney Disease Innovations in partnership with George Washington University School of Medicine and Health Sciences will be a hybrid event, both online and in Washington, D.C., and will take place June 28th and 29th. The 6th Annual Policy Summit will take place virtually on July 28th, and the 48th Annual National Patient Meeting will take place virtually September 20th through the 22nd. And the 5th Annual AAKP Fun Walk will take place virtually December 4th through the 8th, with an in-person walk in Tampa, Florida on December 9th. We invite you to let us know which events you are interested in participating in this year, and we'll be sure to notify you when registration is open. You can also visit us on our YouTube channel to watch presentations on demand from our 2022 events and programs. Thank you again for attending.